I am the president of SCOPE at Loyola. That's the pathology interest group. And I'm an M2. I'm also in the Path SIG interest group as well. I had to think about that for a second. But they have some other events as well. So if you wanted to check in on that on Twitter, that's another great place. My Twitter handle is @Cullen Lilley if you want to follow me. And I know all of our presenters, or at least most of our presenters, are going to be on Twitter as well. And so I'm going to pass this over to our first presenter, which will be Dr. Mirza, and we can get this started.
Sure. Welcome, everyone. So this is a very informal, supposedly informal discussion on what pathology basically entails as a career. I'm going to try and share my screen. The reason I'm telling you that it's informal is because I do have some PowerPoint slides, but that's only because I wanted to frame the discussion. I find that I can frame discussion easier when I'm like speaking from PowerPoint slides, but the idea is for this to be kind of interactive. And again, I'm pretty certain many of the people here have already thought about a career in pathology. And so if that's your, where you are, then hopefully we can further solidify that. And if you are, still thinking about what career choice you want to make in medical school, then this session is basically for you. And we have a lineup of very, very close friends of mine. I'm very grateful to Cullen for like organizing this and putting this together. So what we're going to do is that I'm going to basically I've titled my little section, The Journey of a Specimen, because I always find that I think in medical school education, it's always easy to kind of follow something along, like, like a clinical vignette. And so what I wanted to do was kind of talk about what role a pathologist plays in a patient's life. And that basically will be surrounding a specimen, right? And so that's ultimately what I think we want to do. And then our chief resident, Dr. Aragao, will talk about the day in the life of a resident. Our surgical pathology fellow, Dr. Orezi, will be discussing a little bit about switching from a different career, let's say in medicine or surgery or anesthesia, for example, to pathology. So we actually have numerous people who go into a particular type of career and then they switch because they realize that that career wasn't for them, right? And so, I'll be touching upon making an informed decision to do pathology as a career. And then Dr. Vijayalakshmi Ananthanarayanan, who's also with us. There she is, beautiful smile. She is our program director for the pathology residency. And she will be informally, again, all of us will be informally discussing this. She will talk about what career options you have if you become a pathologist and what the lifestyle is like, because we're definitely all about the lifestyle. All right, so typically when you think of pathology, right, if you're in early medical school, you might not have even heard of it. And typically what people think of is that pathologists are those technicians or technologists that are in the laboratories that are taking care of specimens, or they think of the fact that they are the forensic people who do autopsies, right? And so in general, that is what unfortunately CSI has done to us, right? So you watch CSI and you think that, well, it's just autopsies, and we love autopsies. It's part of what we do. And medical technologists are fantastic individuals who are the front line in laboratory care, but medical technologists aren't physicians, right? And so we work with the medical technologists and medical laboratory scientists. In fact, I run a master's degree for medical laboratory science, so we're very hand in hand. However, people in medical school don't often think about the fact that physicians can choose a life in pathology and laboratory medicine, right? And I think that is something which it's been our mission here at Loyola Pathology to try and clarify. And so I think ultimately what happens is that when you are in second year of med school and you're trying to take the steps, I think step one becoming pass-fail, which is another whole discussion in itself, is going to change the pressure associated with step one. But typically people are just trying to cram for step one. And as soon as that's done, they're very excited in that, okay, now pathology is over. We don't have to think about it. But what I think that I want to reframe your thinking, the attendance here, I think that you need to reframe it because it's actually the application of pathology which starts, as soon as you finish second year of medical school. And if you think of a group of individuals, right, I can't think of a specialty that touches every single person in a crowd like pathology and laboratory medicine does, right? So whether it is a woman who is pregnant and she just took a BCG test at home, right, a kind of a point of care test, or if it's a man who has an increased white blood cell count, or if somebody's PSA is low or high, or if there is a lung nodule that needs to be biopsied, right? Effectively, every time someone comes into the hospital as a patient, they are, interacting with pathology and laboratory medicine, except that they might not be interacting directly with the physician. And I think that's where the sexiness of pathology goes down, in that as physicians, you don't necessarily consider that, oh, there can be physicians who might not meet patients. But that doesn't mean that the job of these physicians, of us, is anything lower. So I'm going to try and actually give you a plug about 3 little pieces that I wrote with Stritch students or with Loyola pathology residents. And this has basically been my life kind of goal, just to make sure that people make an informed decision about pathology, right? So the first one is called Dissecting Brain from Brawn. These articles that I'm showing you are all in the Pathologist. You can quickly find them, but then they're QR codes if you want to see them right now. So Dissecting Brain from Brawn actually came from the idea that if you think of a surgeon and what they're doing, and then think of a pathologist and what they basically achieve, many people actually love the allure of surgery, right? But then when they ultimately do it, they realize that they may not have liked the technical aspect of it. They might have liked the intellectual aspect of diagnosing the tissue, right? And so it's very hard, because when surgeons wake patients up, they will say, Mrs. Smith, we've diagnosed you with osteosarcoma, right? But the surgeon didn't make the diagnosis. It's not to say that the surgeon's role isn't very important. It's ultimately like really important, but the type of career and life choice is completely different. Are you the one taking out the tumor and being really good at the surgery? Or are you the one who's delicately looking at the tissue and trying to make a diagnosis, right? I mean, both of them have their role, but I think what happens is that the role of the pathologist goes down. And often you don't think of pathology as a clinical specialty. You think of it as like a research specialty, right? I mean, actually, pathologists are quite guilty of this. We often call our patient-facing colleagues clinicians, and we don't call ourselves clinicians. And I think that's a huge problem. We are clinicians, right? We're putting together patient data, we're putting together patient findings, and we're making, very life-changing decisions. So it truly is a clinical, field, and we truly are clinicians. And lastly, unfortunately, there was no other picture other than me and Austin McHenry, who was one of our Stritch medical students a few years ago. He is currently a pathology resident at Yale. And I think that, we try to make a case for a universal clerkship. And the reason for that is that when people come to medical school, not Cullen, because Cullen is my favorite medical student, and he already was a microbiologist before. So he was exposed to the laboratory and pathology before he came in. But if you don't have that type of background, or if you don't have a family member who is a pathologist or a laboratorian, you actually have no idea about the lab. So I always joke that medical students come into medical school with this idea of, okay, there's a checklist. And in my checklist, I have surgery and medicine and psychiatry and OB-GYN and urology, radiology. And you have boxes. And as you go through medical school, you cut out things that you don't want to do. And you check in like things that you may want to consider. The problem with pathology, I feel, is that it isn't even a checkbox. People don't even consider it, right? And so my job, I feel, isn't to make sure that everyone does pathology. To be honest with you, we don't want everyone to become a pathologist, because there are very few training positions. It's a very competitive field if you think about just the number. But from every medical school, if you get 1 or 2 people a year applying for it, that's great. But for the rest of them, what I want to do is I want you all to make an informed decision, right? Think about it and rule it out. No problem. Our feelings won't be hurt. It's not a big deal, but you can rule it out, right? So journey of a specimen. So I will talk about the journey of a specimen, but that's already when the biopsy has been done. But I'd like to start off the conversation talking about someone who has been rushed into the emergency department and they were found comatose, right? And they basically were on the road. We have no idea. There's no way that this person can give you a history. So what are you going to do? You're going to order a bunch of tests, and definitely there'll be radiology in there. But the bulk of what you're going to be ordering, the myriad of tests, which could include their blood work. It could include like different, maybe their fluids that you find, that you try and look for, your tox screens. What is all of this when you're sitting on Epic and going crazily typing all of those tests out? All of those tests are pathology, right? And people don't realize that. There are physicians or laboratorians in the labs that are making sure that those values are being taken care of and being, looked at and like being reported appropriately, right? So typically you think of pathology and you think of, okay, well, there's cancer, right? And that's totally appropriate. A lot of what we do is oncology. But that isn't all that we do. And so hopefully in the next 10 minutes or so in my time, I'm going to be able to tell you, we can't go into details about anything, but I will, let's take you on this journey of Mr. Smith, right? He's a 64-year-old man. He has a past medical history of diabetes and kidney disease and smoking. And he's also had colon cancer, which was resected 10 years ago. So he comes in, I think he's coughing. The fake doctor looks really cool, but he's like listening to his chest, all of that good stuff, very decent looking models. And there's also a prominent neck node, right? So when the examination is super important, this session isn't about dissing any other field at all. Like all other fields are super important, right? But it's just to talk about path. All right, so what can you do? You can do a bunch of testing, and it touches different parts of the laboratory where pathologists are, right? So we typically divide pathology into anatomic pathology, and we divide it into clinical pathology, which is also laboratory medicine. So in anatomic pathology, one of the amazing things and one of our strongest subsections here in our department is cytopathology. And cytopathology is the ability to very quickly take tissue out or sample tissue that is accessible by a needle, right? So it's basically usually kind of a palpable lesion like that person's neck node was, and it can be ultrasound guided or not. And actually pathologists see patients because they will be the ones who go and do these biopsies, right? And so it's a myth that we don't see patients completely. There are subspecialties within pathology where we do see patients. And so here you can see there's a picture of a needle, and like you can suck out some cells, and then there's a whole image of how they can be processed. You make a smear of them and you take a look at them, and you can actually give the patient or the patient's patient-facing physician an answer, right? Without this answer, we have no idea what this neck node is, right? Is it the colon cancer that's metastasized? Is it something completely reactive? Is it a new cancer? Is it lymphoma? We have no idea, right? Until the pathologist tells us what it is. So the findings are very ominous, and so the patient undergoes some radiology, which again is really great. Radiologists are very important. They can really bring the differential diagnosis down. But until and unless there's tissue, you won't really know what the patient has, right? So there's a lung nodule. You can't do an FNA. You can't do cytopathology, and so now this patient needs to have a portion of their lung removed, right? So now what happens is that when a portion of the lung is being removed, a different part of the pathology lab comes into action, and that is the surgical pathology laboratory, right? Surgical pathology deals with resected specimens, and when the patient is in the OR, at that time, if the surgeon needs it, you can actually send a small specimen, and we can do what we call a frozen section, which is reported in 20 minutes. So typically when we're fixing tissue, we do it with formalin, and like it takes a day or so, but we can give a very quick answer to surgeons while they are still operating. So it's an intraoperative examination. And this is how the surgeons, with their, power ties, they can basically tell people that, listen, this is what we diagnosed you with, right? Because in between the surgery, there's a little magical elf called a pathologist who tells you what actually the patient has, right? And this is the, best kept secret, unfortunately, of pathology. But even this is made fun of, right? So surgeons, here is a blog where, surgeons sends lunch for frozen section. So, I mean, they can basically send us anything that they want. And I thought this was really funny. But once we receive the specimen, our residents are exceptionally well trained. We will make sure, we measure there's so many things that we do, right? So let's say that this is the tissue, it's come out, there is a lesion in it, and now we're going to be able to tell you what it is. And the process requires a little bit of fixation and processing, and ultimately slides are made. And our residents are experts at this. Our fellows are experts at this, right? And this is how the basis of our pathology training actually happens. So it turns out that this was an adenocarcinoma. It probably was from the lung, and this is a new lesion that he has. And we're not going to go into the details of the report, but every word that a pathologist writes not only changes the life of a patient, but it's extremely important because it basically, it basically tells you what is going to actually happen with this patient. Right? Viju says, even if the surgeon sends lunch for frozen section, pathologists can figure out what he or she ate for lunch. That's exactly right, right? So here what we're doing is that we're saying it's an adenocarcinoma. We're saying 10 lymph nodes were negative for malignancy. Every word makes a difference. Imagine if this was your friend's report or your own report. If this is wrong, right? I mean, people go to hospitals because surgeons are great or nurses are great, and that's all great. But have people ever thought about going to a hospital because the pathology is great? If your pathology is messed up, if you miss this lesion, that's a huge problem. Like you have cancer and somebody missed it, that's a huge problem, okay? So it's definitely important, the role of what we do. So I'm not going to get into staging, but ultimately the staging is important. And now the new frontier in medicine and pathology and diagnostics is molecular. And we need to know what the molecular underpinnings of that lesion are, because there are targeted therapies that we could use. Our oncologists need this data. And who provides that data, right? That data is provided by a pathologist. So, truly the amount of material and amount of love that we give to these patients, while it isn't celebrated directly, it is definitely something that changes the course of the patient's, whole life. And that was just surgical pathology, right? And so let's say that we continue. This gentleman has had a surgical removal, and now he or she is recovering. And post-op, there's oozing from all surgical incision sites. Every medical student should know what's happening. CBC shows that the hemoglobin is low, the platelet count is low. And this is where the laboratory medicine aspect kicks in, right? There are so many things that are coming from the laboratory side that are important. And usually what we do when we orient our M3s towards the labs, we take them to different sites, right? And these are posters. So this is way too much information. But what I wanted to tell you was that the hematology lab is a lab where we are using unbelievably cool techniques, right? There's lasers and scatter patterns and, and physics and chemistry and like all sorts of different things that go into these machines. And in the hematology laboratory, we're figuring out how much the hemoglobin is, what the cell counts are, what the cell morphology is, what's going on, right? What the platelet number is. Let's say the patient also gets an infection, right? We have an entire clinical microbiology laboratory. This is different from microbiology research. This is where we are using things like, there's so many things, like we're culturing the tissue, we're talking about antibiotic sensitivity, we're doing molecular techniques, very, very high-end molecular techniques to discover what the bug is, if there is an infection and what it's susceptible to, right? Similarly, like if you think about the BMPs that you do or the liver function tests, the entire chemistry laboratory, these labs are 24/7, 365. There's no holiday. Everyone is working, and these people are reporting, things to patients all the time. So this is extremely, extremely important, right? So the clinical lab, and the one lab I don't have mentioned here is blood bank. What if the patient needs a blood transfusion? Between doing different types of procedures like apheresis procedures, looking at blood transfusion reactions. These are all subspecialties. You can do pathology and become a blood banker. You can do pathology and become a microbiologist. You can do pathology and become a hematologist. Like all of those things are options for you. Honestly, it's like as broad as all of the medicine and surgery fields, all right? So I have 2 minutes left. And in the end, what I wanted to say to everyone who still can make a decision, it is to do a pathology elective. All right, spend time in a pathology lab, figure out if this is for you. We don't claim that this type of career is for everybody, all right? We definitely know that there are people who will not like not seeing patients all the time, and on the opposite, there might be people who love not seeing patients, right? You have to come to the equation and answer that question for yourself. But I can tell you before I hand it over to our next speaker, that there is intellectual curiosity and differences every single day. Like no one day is the same as the other day. Like, I've been listening to like Dr. Orezi, our search path fellow, and Dr. Ananthanarayanan. They've been talking about how amazing the cases have been, right? I mean, it's fascinating, right? All the cases, like they come in a crop and like every single one of them is fascinating. And, to me, again, while I don't want to diss any other field, but it's different from sitting in a clinic and just making somebody's hypertension medicines go up and down. Like that may not be why you came into medical school, right? Or doing the same appendectomy again and again. So I think that there's definitely some weight in being able to think about, pathology as a career. And I'm kind of glad that you sat through that whole thing. And I'm going to take this back to the outline. Do we remember who was next? Let's see. Okay. So maybe we can just put it back on the outline. Chat box is open. So if in case you guys want to like say anything, we probably will hold the questions all the way till the end so that we don't waste anybody else's time. Hold on a second.
So next on the schedule, we have Dr. Aragao. So
there we
we're
go.
Going to move on to that. And we're going to be looking at a day in the life of a pathology resident.
You guys hear me?
Yep.
Hi, everybody. My name is Alessa Aragao, And I didn't prepare any slides, but
No problem.
I will tell you guys how it's like to be a pathology resident. I personally love it a lot, so I'm very biased. But I like to say that we are the internal medicine of diagnostic medicine. It's a very, very dynamic field, and really there's no way you can get bored, in the sense that you're always getting experience into different areas. So one month you're rotating at surgical pathology, another month you'll be on microbiology, another month you'll be on cytology, and it's so much fun. For personally, like, there's no way you can get bored with, you know, something that's so dynamic and so interesting too. So as a matter of fact, today I'm on laboratory management. This is my rotation for the month. And I had also an autopsy presentation to do. And for me, it's very gratifying when the attendings that have so much clinical knowledge come up to you and say, wow, this is so interesting, what your autopsy findings. And, you know, for us to teach them something, to show them something different, to show them, like, you need to take in consideration this, you know, this is when you ordered an autopsy, or make sure, like, when you're treating these patients, to take a look at, you know, certain things. That for me, it's wonderful. So like Dr. Mirza had previously said, if you do have an opportunity to try out pathology for a month and to get the exposure, definitely do this, because you need to be exposed for you to see if it does fit your personality, if it does not fit your personality, if it's something that you would like to do as a career. And I think even when you go into pathology, there's so many different fields you can go into that it's very unlikely that you will regret this decision. So other than that, like having that said, Dr. Mirza also talked about the anatomical pathology, which I think most people, when they think about pathology, they associate like autopsies and biopsies. And they forget that we also have the clinical pathology field, which both fields are expanding, and there are many ways for you to grow into, you know, both fields. And as a matter of fact, like, one of the biggest examples that I have for you guys now is the COVID period. So in March, I was actually on my chemistry rotation, and we were validating new machines for the hospital to be able to test people for something that didn't even exist before. So we were, you know, seeing how would we use different machines and validate them to test everybody. And this was a huge impact for the hospital and for the community in general. So what else do I want to tell you guys? Also, I think one thing that's very important for you guys to know is the interaction that you get with many different fields. So you're always going to be interacting with, you know, from peds to thoracic to cardiology. You're involved with many different fields within the hospital. And I think that is great for, you know, for yourself, in the sense of like learning. You're learning every day, you're interacting every day. And it's, like I said, it's a great field to go into. So yeah. So if you guys have any questions.
So I know that are you a first year resident, or?
I'm a fourth year.
Fourth year, okay. So I know that like a lot of specialties do internal med as their first like year. Is that also the same for pathology?
No, so in pathology, you do not have to do a first year of internal medicine. You go straight into pathology. Yeah.
Cool.
Yeah. And there's also like different programs that offer different rotations. So some programs will offer like an entire year of anatomical pathology, rotating with like an entire year of clinical pathology and then back to anatomical pathology. Here at Loyola, we do a mix. We, keep things a little bit more dynamic, which I personally love it a lot because I feel like if I do just AP for a year and go back to CP, you're not keeping that constant interaction. So I think I don't like that big gap between the two. I like to always, keep going back and forth between AP and CP. I think that's very helpful.
Mm-hmm.
Any other questions?
Could you talk about a little bit about the different types of residencies that you can go into as a pathologist? If you want to do AP only, CP only, AP, CP combined, or maybe even, AP, NP, something like that.
Yeah, so usually, ideally, it's better for you to do AP and CP. It makes you more competitive, and it also makes you a better, pathologist in general if you have both backgrounds, I believe. But you can go into AP, you can go into CP only. So you have that option if you feel like it's not for you or you don't think it's going to make that much of an impact in, what you're trying to go into. And afterwards, you can choose if you want to go into which field you want to go into. So personally, I'm going, like, my field of interest is cytology. I love a bit of everything. So I'm going to do another year of surgical pathology and then doing a year of cytology. I also personally really like, microbiology, but I chose not to go into that field. But there are many fields for you to go into afterwards. You can go into, from cytopathology to dermatopathology to blood bank to molecular microbiology, and what else? There's so many things that you can go into that it's a good area to. I think it's very unlikely for you to go wrong in this field.
Thank you so much.
Let me see if there's any questions on the chat box. Yeah.
I think we can just move ahead.
Okay.
Thank you, Dr. Aragao.
Thank you.
Okay, so next we have Dr. Urazi, and he's going to be talking about switching into pathology from a different field.
Wow, that was a fantastic pronunciation of my last name. Like, without hesitation, you said it correctly. So bravo.
Awesome, thank you.
Yeah, so I think, my segment here is about switching into pathology, but I think the hope here is that you never will have to come to that point. Hopefully you'll make the right decision on the field you want to choose before that, but rest assured that people do make switches. So a little background about myself. I went to the University of Rochester for medical school. I graduated in 2014. In the middle of medical school, between my second and third year, I did a research fellowship in Boston in echocardiography. So I was really, really angling towards becoming a cardiologist even before I finished medical school. I entered internal medicine residency in 2014 at University of Chicago. And about halfway through my intern year, I just found that I wasn't enjoying what I was doing. And it had been kind of building up over the course of that year. And initially, people said, "Oh, you're just getting used to being an intern," especially after being a fourth year medical student. Fourth year of medical school, especially the back end, can be a lot lighter, and all of a sudden you're thrown right into it. But it was something more than that. Even in medical school, when I was pulling long hours, I still got a lot of fulfillment out of what I was doing. But I was coming home during my intern year not feeling excited about what I was doing. There was something that was missing. There was that intellectual engagement, that aspect of it that just wasn't there anymore. And finally, I got to the point where I said, something's just not right here. I'm not enjoying what I used to like about medicine. And so when I sat down and I made a list of the things that I really liked during medical school, I said, well, I loved anatomy. I actually really liked histology. This was back when they still had microscopes in the histology lab courses. So we actually used the microscopes and looked at slides of sections taken from animals, actually. So we got to see all the organs and everything in real time using a microscope. I actually enjoyed that part of it, but I sat around a lot of people who always were belittling it or just said, oh, I hate this and that. So I think that projected onto me a little bit in some way. But I loved anatomy, I loved histology. And even during my medicine sub-internship, I remember I had a patient who had dermatomyositis, and I got in touch with the neuropathologist to see if I could see the muscle biopsy for that patient. And I remember really thoroughly enjoying it as well. But I never ever connected the dots. I didn't seek out, first of all, I didn't seek out any sort of interest group like you guys are doing, which is the first step. Number two, there was even options at a lot of institutions to do a post-sophomoric fellowship. So between your second and third year, you do a year out and you essentially function as a first-year pathology resident for that year and get an immersive experience. And then you come back to medical school for your third and fourth years. And at the University of Rochester, where I was a student, there actually was a very, very solid post-sophomoric experience that 2 to 3 students a year would do. And inevitably, 1 or 2 of them would go into pathology, but even the ones that didn't came back saying, wow, I really have developed an appreciation for what pathologists do. And I could see myself actually doing it. But now I know sort of what things that the pathology lab can do for me. I didn't seek any of these things out. I didn't do a pathology elective. I coned in pretty fast. You know, everyone sort of says, I'm trying to keep an open mind on, you know, all these specialties. But I think you might not notice it, but you might find yourself going down a certain track without exploring everything. So halfway through my intern year, I reached out to my program director, who in turn reached out to the program director of pathology at the time at University of Chicago. And she contacted the chief resident at the time, who just happened to be our very own Dr. Mirza. And he welcomed me to the department, set up a schedule for me, and I spent about a month rotating through there. And within a few days, I was like, this is what I want to do. How did I not discover this in the first place? Like, I was excited to go in every day. It was just every day there was something crazy that they were showing, something new, something novel, something, you know, you read about in textbooks as a classic example, you'd study for it on step 1, and you'll never see it again, except for that rare instance in your career. But in pathology, it's almost like you see it every single day. So I was sold on it, and I did a year of research in pathology, in cardiac transplant, antibody-mediated rejection with Dr. Hussein, who was the program director at the time of U of C, and then I started residency shortly the year after that. And I finished up this past year. And now I'm here as a surgical pathology fellow at Loyola with plans to do cytopathology after that as well. So I guess I've kind of rambled on here a bit, but there's 3 sort of take-home points that I want you to take away from all of this. You know, 1, be very, very honest with yourself. I mean, really sit down critically, you know, not just, you know, and pay attention to how you feel when you're on your various rotations, especially your third year. Like if on internal medicine, you're not enjoying rounding for 3 hours at a time, you know, or writing long H&Ps, like pay attention to that. Don't ignore it and say, well, I'm just going to power through it for these 8 weeks on internal medicine. And then, you know, it'll get better when I'm an intern. Like you have to enjoy it. You have to be getting some kind of fulfillment out of it. And if you're sort of shrugging it off and saying, well, no, I'll adjust to it and I'll get better, you need to listen to that and evaluate it. It can also be difficult because sometimes you may have a very small exposure to something and it might not be with the right people, or just circumstances just weren't right. So try to dissect that out from your experience of the field. Don't let, you know, one negative experience in something cloud your experience or your perception of the specialty as a whole. Now, I'll say that in pathology, you're not going to run into those sorts of negative experiences because everyone just seems really happy. And that's one of the things that I wish I'd maybe listened to a little bit more or paid attention to when I was a student rotating through was just the subtle things people did, you know, when they were rounding, you know, how they talked to one another. In pathology, you'll find people working late, but they're just still excited about what they're doing. So definitely pay attention to those little cues and be honest with yourself, and sort of do an evaluation after each of your rotations and say, what did I like about this? What did I not? Can I see myself in that position? And along those lines, I would say to choose in the end what you want and not what others expect you to do. I think I had done so much, in the cardiology realm that I sort of created this perception around me that, oh, you're bound to be a cardiologist. That's what you're going to do. And I think that pressure sort of kept pushing me along. And at some point, again, if your heart is not entirely set in it, an intern year and residency is going to bring it out, because residency is tough. No matter what field you go into, you're going to hear about lifestyle, and pathology overall has a great lifestyle. Being able to go home every night and not have in-house call is something phenomenal. But that doesn't mean that we don't work long hours. And when you do work those long hours, or you have that really heavy caseload, you want to be doing something that you enjoy. And I found that there were times as a pathology resident that I actually worked, especially on surgical pathology, I may have even worked more hours than I did as an internal medicine resident, but it never felt like that. Like I just was there till 10 or 11 looking at these amazing cases and learning from them. And I was excited to go in the next day early in the morning. So if you can find that sort of passion, then that's what you're looking for. That's what you want to try to nail down. So don't feel pressured from the outside on what you should be doing. Just think about what you want to do. And, so one of the things I did want was, a more balance in my life. And I felt like with the 30-hour calls and working weekends, I mean, a golden weekend should not be like that. It's a normal weekend. Like in pathology, that's a normal weekend, so that was an important thing to me. I wanted to have that balance in my life as well. So listen to that. Some people thrive on the, being on the long 30-hour calls and neurosurgery and all, and that's great. You should listen to that and pursue that if that's what really gets you excited every day. But if it's not, again, pay attention to that. And for those of you that decide not to go into pathology, I think it's great that you're at least exploring the field. If anything, it'll make you a much more informed clinician. You'll know, say you become a surgeon, there's probably going to be a handful of you that do end up going into surgery. Having explored pathology, you will know what is a good intraoperative consultation, like what questions can pathology reliably answer for me, in that time. You'll be making much more informed decisions, and you'll know sort of there are things that we can do that you might not even think of. So for instance, I did a radiology elective for 2 weeks in my 4th year of medical school, and I came away from that with a really good basic understanding of how to approach films, because you're going to review films as a pathologist too. Like you're on thoracic pathology with Dr. Viju, for instance. I mean, we have to review the imaging sometimes to know is this mass pleural based, or is it within the lung parenchyma? How does it correlate with what we're seeing? Like you have to know how to do those basic things. So all these experiences you have, if you do electives in derm or pathology, radiology, like it's all going to come together really nicely. So that's another reason why you should explore widely and delve in. And you're at an institution here at Loyola where it has a phenomenal pathology department and elective and rotation. I mean, it's so well structured that you're going to have a very good comprehensive experience. So I think I'm getting close to the end of my time, but I'll leave it open for any particular questions.
Do we want to move on to the last section? We can save questions for the end.
Sure, that's fine.
Okay.
Thanks.
So, no, thank you. And so last but certainly not least, our own Dr. Viju, and she is going to be talking about career options and the lifestyle in pathology.
Hi, everyone. Nice to see you all, especially on a Friday evening. And I thought I'd share a little bit of my story on how I got into pathology in the first place, because that's one of the commonest questions that I get asked during the interview season is, why did I choose pathology? So I am a thoracic pathologist, and it's a subspecialty of anatomic pathology. And I have been at Loyola for the past 6 years. but I have been a pathologist for at least 18 years. So I grew up in India. I did my med school in India. And obviously, that's about, say, 20, 25 years ago. And the situation is not the same. I was the first, probably the only physician in my family. Didn't have any exposures or even anyone to guide me through the process of getting into medical school, let alone the career paths that come after getting into medical school. So getting into medical school, obviously, just like Imran said, I was fascinated with physiology. I loved pathology when I came into second year. And of course, in India, the second year of medical school training has a lot more exposure than you kids get. I'm sorry, not kids, than you medical students get in the United States, because everything is, case-based vignettes and, fewer things. We had to handle gross specimens. We had to actually look at glass slides, make the diagnosis, and so on and so forth. And we even had to make journals where we had to draw exactly what you saw. So you would draw a histology for how the normal lymph node looks, and you had to draw how a granulomatous lymphadenitis looks. And that reinforces a lot of pathology in you. So going in, so I was like, okay, I like pathology. And then, year 3, I go into internal medicine, and I am in love with internal medicine. I love it. I'm fascinated by Harrison, and I just find like every time there is an explanation on why there is a murmur sounds like that, or now I don't even remember why there is an S3. I used to find that really, really, really fascinating. This is really cool. So then I say, okay, first choice is internal medicine, second choice is pathology. And the system is not similar to what we have here. So you could apply to multiple programs, and you could be on waitlisted and whatever, right? So I apply, and I want to get into internal medicine, and scores are not good enough for me to get into internal medicine. And I've also realized that the ones that I actually like the most, I actually perform the worst when it comes to the scores. I used to get really high scores in surgery. I had no interest in surgery at all. But, I think that when the pressure is not there to perform, then you tend to do, better. Anywho's, so I get waitlisted for internal medicine. So, and then they say, oh, you don't have a position right now for internal medicine, but if you want, we have a pathology opening for you. So, and then I said, okay, all right, then I go in for the pathology. So then I'm like 1 month into pathology. It was not my first choice, but still it was there. So I go 1 month into pathology, and then I get a call back 1 month later saying internal medicine is now open. Do you want to switch? Now, I don't know it's always a momentary decision. Okay. We don't have so many, we don't have this month. You don't have a formal interview. It's a very different process. I'm sure it's changed now, but this is when I did it. So it's just like, you have to go into this room where you have 5 people sitting, and then you just go in and they say, okay, this is the place, you've been matched to this place. Would you like to go pick this, do you want to go into internal medicine at this point? And I say, no, thank you. And I walk out. And I didn't even think, and I walk out. And that whole night I cried because I didn't know why I said no. But now looking back on it, I probably saw something. There was something about pathology that kept me grounded, that I wanted to continue pathology because I'd already done for 1 month. And the experience that I got out of it was obviously valuable. But that was probably the last time that I cried because for making that decision of switching into pathology. So then I completed my residency in pathology, and ours is a 3-year program in India. And then I came to the United States, and then of course, immigration problems, so on and so forth, and so on and so forth. And then maybe after, say, 7 years of research, getting a valid green card, then applied for pathology programs here, did my first year at George Washington University, and then transferred to University of Chicago, where I met my dear friend, Dr. Mirza. So even though he's 1 year junior to me, we actually started the same time because I transferred in as a second year resident. And then I stayed on, and then I did my thoracic fellowship with Dr. Hussain, who is also mentor to Dr. Urezi, so you can see how we connect the dots. There are so many different things that in life, that come back a full circle. You think you have gone far away from it, but it comes back and brings you back to the same point. So the point that I'm trying to say is, what is it that brings you or attracts you to pathology? And if someone asks me this question, and if you are one of those who want to know why of something, how of something, rather than what to do when something happens, then pathology is for you. So like, if someone asked me what would have been my choice if I had not been a pathologist, I would have probably said a detective. Okay, I would have loved to be one of those characters in Perry Mason's novels, or I grew up on Three Investigators. I know you guys probably didn't read Three Investigators, but I used to love being the secret sleuth who would investigate and figure out what's going on and so on and so forth. So anyway, so I think that passion for detection has been in me for long. I'm also a person who gets very emotionally attached to things. So if you are among those people who will get attached to every patient who comes across, during your interactions, during your clinic, don't think of internal medicine or surgery or even emergency medicine. Pathology is for you. It's not that we are not emotionally attached to our patients, but it's a very different kind of attachment, right? Like it's not the same as having a person in front of you and carrying all their troubles, all their pain, and all their sufferings with you back home, right? So I think that way is, as a career choice, is very useful, and you don't bring along someone else's trouble back home. Yes, it does bother you. I'm not saying we are not empathetic. Okay, we are all very empathetic physicians, but it's a very different kind of empathy, right? And it's not that we only give bad news. I think that is also very important for people to realize that not every nodule that is detected on a CT scan is a lung cancer, right? There are times that n number of times that they've had a CT scan done. There is a nodule in the lung. They follow it up with a PET, and it is PET avid. The radiologists, the surgeons think this is malignant, has to be malignant. They take it out, and lo and behold, it's a granulomatous inflammation. What better news can you give to a patient that there is no malignancy, but what it is a pure infectious process? Okay, not that infectious process cannot be bad, but it still can be something that you can manage, right? So I think that is what you have to look at, and this is what Imran was saying about. You have to know what you want to do, and when you go in completely informed. So don't do like what I did. I mean, we didn't have the opportunity. You guys have the opportunity to go into pathology electives, so try it out. If you really want to stay away from it, then at least follow your specimens through. When you are on surgery rotations, stop in by the frozen section room, see what the pathologist is doing. Because what as MS2 lecturers, what we do, that's not what we do on day-to-day life, right? We are not just the ones who are doing only autopsies or giving PowerPoint presentations. There's more that we do. Now, as far as career choices as to why it is, so like Alessa said, you could be a pure anatomic pathologist, you could be a pure clinical pathologist and a laboratory medicine physician, or you could be a blend of both, which are vast majority because that's what we do, or you could be in private practice, you could be in pharma, you could be in a research setting. If you are one of those PhD guys who would like to do and have your own lab, there isn't a discipline better suited to doing a lab and doing research work hand in hand. So in fact, the NIH likes scientists who are physicians by training. They do like the grants are actually really favorable for them. So it's actually very, very good. As far as long hours, we do work long hours. I don't know, there is a huge misconception among people that it is a 9 to 5 job. I have had, once I walked in with my bag, of course, around like 9:30, I sauntered in with headphones in because that's what I like to do. I saunter in and the surgeon comes looking at me and he says, "Oh, you're walking in right now?" And I said, "Yes." But the fact that I stayed till 8 p.m. or 9 p.m. while you were back home at 4 p.m. or 3:30, you didn't know about. Right? So when the surgeons finish their job, the job of the pathologist starts, right? So I think that is what it is very important. So it's a different kind of long hours that you're going to put. Now, the other advantage is, let's say you have children to be picked from daycare. You have the flexibility. Okay, it's a surgical specimen that is there. You know that they know that, yes, you have to meet your turnaround times and everything, but it's not going to matter whether you're going to finish it right now, then and there, or whether you come back early in the morning tomorrow, or you come back on a weekend to finish that job. So that flexibility, you're never going to have with any of that. There is a patient waiting in the room, you got to go. You're not going to have that flexibility if you're, if you're in any other discipline. Maybe radiology, I mean, that's the closest that you get. But we do see a lot more color than radiologists do. It's a lot more fun. It's much more visually challenging, visually appealing. The more you do, the more you learn. There isn't something that I enjoy more than sitting with my residents and fellows and opening a book or searching on internet, what are the combinations, what's the diagnosis on this, because every day has a new challenge. And I think I told this earlier too, I don't know which group I said to, I feel like even as 70 or 75-year-old pathologists, you still have the same degree of enthusiasm that you have on day one, which I don't think you have that same degree of enthusiasm in many other specialties. Not because you don't want to, but you get bogged down with so many other red tape, bureaucratic things that happen in day-to-day life, right? Between, insurance companies, between not having the adequate administrative support and things like that, and so on and so forth. Here you can plop in your slide, put on your music, work on your cases, watch YouTube videos at the same time, and still render a diagnosis. You still have to do your job correctly, but I'm just saying you can, to some extent, do a little bit of multitasking. Like Imran's case, we have had a couple of residents in the past who have switched from surgery after being 3 or 4 years into doing a surgery residency. We have had one who switched from anesthesia. It's not to say that people don't switch out from pathology. Of course, there are going to be people who switch out from pathology too. But again, people who have switched in have not switched back out again. Let's put it that way. So, so I think that's a good thing. There are people who do other things at the same time. We've had one resident who has done an MBA. I'm sure you can do, there are programs where you can do an MPH at the same time, just because it gives you the time, you are able to do it. Again, you are going to be piling on a lot more on yourself, but you can do it. I think that's all I have. And there was a cool case of autopsy that I had to tell you guys. So there was a case that I think was a patient about 53, 55-year-old who kept coming with fever of unknown origin. They tried a bone marrow biopsy. They tried a liver biopsy. He had increasing liver enzymes, and then they tried doing a liver biopsy, and then he became increasingly coagulopathic, and then had a massive hepatic hemorrhage, and then he had to go in surgery and so on and so forth. So we did get some tissues at all times, but we could not pinpoint a diagnosis. We couldn't explain what is causing this patient to fail. And then finally, of course, there was an autopsy that was done on him, unfortunately. And just, as I was, looking at the slides, couldn't come up with a definite diagnosis. And just as I was about to take out the very last slide that I was about to, look at, all we could see is there were tumor cells filling up the vasculature. And this is a condition called intravascular lymphoma, which is as sneaky a disease as it can be. You don't see masses anywhere. It's purely in the circulation. And so the pathologist had the final say, and so these are extremely gratifying moments for you. They might be few and far in between, but you do get an occasional one where the surgeon or the clinician calls you back and says, I'm glad that you made the diagnosis because we were not thinking along those lines. And yes, you don't get a patient to come and hug you or say that, okay, this is good, but this is gratification. It's not that you're not working for the patient. You're all working for patients in some form or the other. Yes, you are behind the scenes and working. So what? You're still working for the patient. So I think that's all I have. And if you have any questions. Or what else did I have to say? Did I have to say anything? No.
That was really nice. I actually knew your story, Viju, but I had forgotten your story, and it was very nice to hear the story again. Thank you so much for sharing that. So I hope everyone is convinced. So you can ask us your questions. We still have 5 minutes. And we're willing to hang out for a few more minutes because obviously we're a very happy bunch who are happy at work. So you can either post them in the chat or you can just unmute and let us know what your questions are.
Before we get to the questions, I just wanted to thank everyone for coming. This was a really amazing session. Thank you for all the panelists, all the presenters. That was amazing. Thank you for their time. Also, thank you for all the people that are not part of Scope but found this through Twitter. This is an amazing time to see everyone here. I know we're all socially distanced, but it's really great that we were able to get this to a broader audience. So thank you so much. And we can move on to questions.
Hello everyone, this is Monica. I'm in the process of residency application and applying for the pathology residency. Recently, I did an observership in Brown University in Providence. Dr. Mirza, you just mentioned that you have virtual slots. So is it possible for me to get an opportunity for that?
So thank you for bringing that up, Monica. So because I already told people in the chat, so I think it might be worth spending a minute or two on. So our chief resident, Dr. Aragao, and our program director, Dr. Viju, and we have put together a mechanism for people across the country or the globe, if the timing is okay, for them to apply for a virtual elective. We have a mechanism for you guys to zoom in virtually and like be part of the team. There are very select slots for this because we could offer this to like hundreds of people, but then the experience would not be good. The idea is to be able to give people who are in the pathology match this year, who don't have the opportunity to fly in and do electives with us in person. We've worked really hard to develop this. And so next week, hopefully our applications will go up. We are expecting that a lot of people will probably apply only because there are very few places actually doing this. And there are many people who want to have this experience. And so we'll have to make some tough decisions. There'll be very limited spots, but Monica, absolutely, you can apply for this. And if you're on social media or on Twitter, please follow our Loyola Pathology account because it'll most likely be going there first. And then we will be putting a link on our website. We're in the process of making a new website and that will go live next week as well. And so we can basically find the link from both those spots. So absolutely anyone can apply.
Thank you so much.
You're welcome. Anyone else? Any pending thoughts about like pathology? Yes, Patricia.
Hi, everyone. I'm applying for pathology as well, but I have a question about the job market. How do you think that's gonna be the job market after the artificial intelligence and all this technology that's coming?
That's a really, really good question. I'll take a stab at it and then I'll request Dr. Viju to take a stab at it also. So I think that, so people have asked me that question before, and I don't think that artificial intelligence is going to replace us entirely. I think that the beauty of pathology is that so for example, let's go back 10, 15 years, right? At that time, molecular pathology and all these genetic mutations were coming up. And the idea was that this will really change the face of pathology and we won't even need to see the slide. But the reality is that didn't change because pathologists used them as ancillary tools in their diagnosis. So I completely agree. I think artificial intelligence, let it come, let it be great. I think the job of a pathologist is to make sure that artificial intelligence is used properly. And then just like we use stains, right? We use special stains all the time to help diagnose something. I think the time will come when we might be using artificial intelligence to help us make that diagnosis. But will it replace us entirely? I think that's very tricky. So, the example I typically give is, if your father or mother have colon cancer, would you like a robot to diagnose that or would you like a human to diagnose it? It's I would be much more comfortable if a human diagnosed it. And if the robot assisted, that's great, no problem, right? The robot assisted diagnosis, I think, is fine. Dr. Viju, what do you think?
I agree with Dr. Mirza. This discipline's there for a really long time, right? Like in the sense, and I feel it's constantly evolving too. So even though we think of pathology as being very, very, very standard or whatever it is, for every new technology, there is a new pathology that comes through. For every new drug, there is a new consequence that comes through, right? So initially you would never know like some of these monoclonal antibody inhibitors and that, you know, toxicity is associated with it, and what are their reactions. But that has now become a discipline. Like you would have to be trained in pathology to even recognize it. There is no way that you could retrain. You know, it takes a lot of research, a lot of things to come to be constantly incorporating that information to be training your residents, right? So, and like I said, this is one thing that is something that you're learning every single day. And I can't imagine a machine to be constantly learning every single day and forming these neural networks, which is what we are doing, right? When we are recognizing a pattern, it's not just a pattern. There is a pattern that's formed somewhere. We are not like a machine analyzing it. We are putting all this information together and spitting out that diagnosis. But that thing is done by our own neural networks, which we are not able to tap into. Same thing, the easiest example that you could say was there was a artificial image analysis technology that came about for detection of micrometastasis, right? This was there when probably at least 15 or 16 years where you could do that, you know. Yes, you could do that, but you still rely on the pathologist to finally say that, okay, there is micrometastasis or not. It helps identify it for you, but for every something, there is some kind of background staining that you have to be sure that's not picking. You have to be sure that what it's picking is not in the wrong cell. It has to be in the right type of cell, that it's not a plasma cell that's staining for something when you're looking for an epithelial cell. So for like every new thing comes, there is a new challenge that's going to come. And I think that's where the pathologist comes in. Like, you know, you are that rather than just giving it to a machine, right?
Mm-hmm.
I think it might also come in handy for like maybe the machine will, you know, will screen cases and tell you which ones might be like high likelihood of malignancy or something. So then it'll tell you what order you should look at the cases in. Because like today alone, for instance, at the bottom of the stack, there's this gastric mass biopsy that I probably should have seen a lot sooner. But maybe with that technology, it'll say, oh, you should look at this one first because this one, you know, is a higher priority or has a higher likelihood of being something that needs more urgent action or something. So I think they'll be assistive tools and not replacements.
And I also would like to add something to that, because since we're in the diagnostic field, even if it grows towards that, you know, even if it goes that way, we're the ones detecting like what's going on, like what's wrong, and, you know, how can we correct this? Why did this, you know, microbiology new machine gave a diagnosis of this microorganism when we know that this is not the correct thing? So we're also learning to, you know, pick up on what's abnormal, what the new technology is like, not truly telling us, or like when are they wrong. So.
And I think one of the best examples that we can give to really make you comfortable, Patricia, I'm putting in a word in the chat. It's called television. We're already there. We're already using artificial intelligence to help assist us in doing these things. So for example, in hematology, the software that we use to do an automated differential count, like it sorts out, like, you know, when the human sits, we look at 100 cells and we count them. This can count like 500 cells. I go blip, 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 and it'll put them all in front of you, right? And so, you know, I mean, sometimes very rarely it's wrong, but you can but you're still looking at it with your eyes, right? So there is an artificial component, right, already in laboratory medicine that we use. And that's such an amazing tool that we, I mean, will that machine call acute leukemia? No, we'll call the acute leukemia, but it's already something that we're using as a tool. So I think that if we use that same algorithm for how we'll incorporate the artificial intelligence, I think that we'll only become better diagnosticians, I think, with it. Thank you for that question. Good luck with the match.
Thank you.
I absolutely agree with what everyone's saying. I think it's really amazing. I think Dr. Mirza and I were actually just talking with an AI pathologist in Israel, and it's just amazing what's been going on. And with my experience in microbiology, I mean, you would think that microbiologists would be extinct, but really they're just taking on new roles. And the classic microbiology bench is still working. But now we're moving into whole genome sequencing and MALDI-TOF, and now with whole genome sequencing, we have bioinformaticians. So actually the field is really growing and it's really exciting. So that's a really good question.
How do you get into AI pathology? There's not exactly like a fellowship for it.
No, I think that, so there, for example, it was similar to how like a long time ago, like maybe 5, 6 years ago, there was a need for informatics. And so like people started developing informatics pathology fellowships. And I wouldn't be surprised, like already there's some centers that are doing a lot of digitalization and using AI. And I wouldn't be surprised that in the next few years or so, maybe Andrew, you can actually create the first, be the first AI fellow if that's your interest. But I think that there will probably come a point when if we can use it enough, right? It's the same with molecular genetic pathology, right? There was never a molecular genetic pathology fellowship 10, 20 years ago, but now those fellowships have started propping up. And so I think if we have enough material to teach someone to become an expert on it, I think slowly and steadily, it won't be widespread, but probably some centers will start developing some sort of version of AI in pathology or diagnostics.
Yeah, I think the other thing that I think we could probably use some help overall would be something very similar to what radiologists do, is that where everything gets scanned. But of course, this requires a lot more, IT support and, infrastructural support, because it's not that, and it's not going to be, it's also going to be adding to the time, right? But it's not like radiology where a person walks into the CT scanner and you have the image that is read. You still have the biopsy that's taken out. You still have a lot of labor intensive process where there is a processing involved. It's cut into slides. And of course, for bigger specimens, you can have up to 60 or 70 slides for one case, for one resection, from counting lymph nodes to specimens and things like that. And if you were to scan all those slides, there is a lot of infrastructure requirements for that. But I'm sure that eventually, as these, as technology becomes more powerful, just like our trainees right now are learning over Zoom rather than we were, traditional glass slides over a microscope. But now we are having pretty much all our discussion and everything that is done in this format. So eventually, I think pathology will go there, but I don't think a time will come where, at least for maybe another 100 or 50, 150 years, that the pathologists are going to be totally replaced. But before then, God knows, another COVID will hit. So we will have something else to worry about.
I have a feeling similarly, like I think the diseases have evolved also, like our ability to pick up diseases. Like there's certain diseases, probably recurrent infections, that just like COVID, for example, that weren't there like so many years ago, or we couldn't detect them. But I think that as our technologies become better and better, we'll probably get better at looking deeper into cells, and like maybe even, preempting things. I mean, I think that there's a world of opportunities like in this.
So unleash the perimason in you.
That's right. Right. Unleash the Perry Mason. I completely agree. So we're over time a little bit. If there isn't any like burning question left over, okay, Vorapat has a question. Okay, go ahead.
Oh yeah. Hi, my name is, good evening, everyone. My name is Vorapat. I go by Pat here in the US. I'm general practitioner originally from Thailand, and I just graduated with Master of Public Health here at UNC, and I'm staying at UNC for research assistant position. My questions, I personally enjoy being general practitioner. I really like being a generalist, and I want to thank you, Dr. Everyone here, and Dr. Aragao, to say that pathology is actually internal medicine of diagnostic medicine. That's really hit me, and because I really enjoyed everything about the whole medicine stuff. And my question would be, as I have my public health degree and a global health certificate, how do you guys see a pathologist's role in public health arena? And and my second question is, I also have interest in quality improvement very much, and how would I combine these two skill set of mine together?
I think you see us all shaking our heads. We all agree with that.
We're also excited. We're like, oh my God, this is amazing. Yeah, that's such a fantastic intersection. So let me quickly
this group already knows about pathology, and they already have made up their mind about pathology.
I know, but
made up my mind.
I'm pretty certain that there are one or two people who are still like young enough to change their minds, and I'm hoping that seeing all of this discussion will make them convinced. Yeah. So I think I'm going to ask Dr. Viju to talk about the quality part of it, because that's definitely her area. I don't know much about the global health perspective, but I can tell you that if you go to pathollective.com, there is an entire section on global health and pathology, right? And so it's extremely important to think about public health, to think about healthcare, inequities, or disparities when it comes to testing. When it comes to the global perspective, there's definitely now, opportunities to investigate global health with a pathology angle. I know that, for example, ASCP has like a global health fellowship kind of where you can go like to an underserved nation and kind of learn or, implement things. And so I think from the perspective of public health or global health, I think that's definitely up and coming. Most likely that fellowship will be up much before the artificial intelligence one. And then obviously like between Dr. Viju and Dr. Aragao here, like there's so much you can say about quality.
Alessa, do you want to start?
Yeah. First of all, I think like your background, that's like a very big positive for you, because it does like, different backgrounds in pathology. That's one of the things that I like most about even my colleagues is that, people sharing different backgrounds, I think they bring something different to, to a discussion or to, I'm originally from Brazil. So imagine how many, microorganism or infectious disease I have seen. And I have even my colleagues, joking around with me, saying along with like, welcome to the jungle. And I was like, you guys are bullying me. But having that said, jokes apart, it brings a different perspective. So imagine like everybody together, sharing their, different backgrounds and, how can they see and how can you diagnose things, or like, then here I come, like they're always waiting like, oh, so how did you know it was this parasite? And then I give examples of things that I have seen. And I think, for us, we share that, interaction. And for the quality, I'll let Dr. Viju start too, but I'll chime in to give a little bit more of an input.
So, the QI things are all, they are becoming increasingly, like everyone is mandating that everything is, has the QI processes in place. In fact, even residency programs, even at the GME level, they want residents as during their trainees to participate, because it's never too early to learn that quality is what matters, right? It's, quantity, yes, you have to, but there's no great thing about doing so many things, or, if the quality is not great. So it has to be combined. So everything, so there are a lot of QI projects that are residents involved. There are a lot of committees that are at the hospital based, where it involves the pathologists, and then there are clinicians who are on that. So the hospital QI committees have, in fact, our liaison for that is Dr. Khan, who's our quality director, and what is the term for it? He's not laboratory diagnostic.
Quality medical director, right?
Quality medical director for that, and he's been on so many hospital committees. So I just wanted to give an example of a case that we had that when I was a resident at University of Chicago. I think what had happened was, and quality, of course, they come hand in hand with even safety measures, right? So they come QI, and then safety all come together. We had a case. There was a CT guided biopsy. I keep telling all these stories all the time. There was a CT guided FNA that was done on a patient who was in a room, and I think what had happened was they didn't get, it was a dry pass or something like that, okay? And they couldn't get it, the procedure was aborted, there was no sample that came from that thing, from that patient, but the pre-labeled vials were in that room, okay? Now this patient goes out of that room, another patient comes in for a totally different procedure, and I think, and a different site altogether, maybe, I think, and so adrenal nodule or something, and this or some other completely different procedure, and gets put into this pre-labeled container of the previous patient, okay? But as pathologists, because of the fact that what histology is supposed to look like, and because this was completely different from what was expected for that, patient, Then the whole thing started an entire chain of events on safety and safety protocols. And then it went down, and then we figured out this whole story much later on how the mix-up was at at the collection end rather than at the end of pathology, because that's the first thing that you think of. The mix-up is from our end. So we then start with, okay, did the person who grows, did they take 2 specimens at the same time? So there are a lot of opportunities as residents, as faculty members to be involved in QA/QI projects. You are judged. Every lab is has certain number of, like anything, has certain number of QA/QI metrics that they have to maintain for certification and accreditation. And there are institutions that will come for inspection. They have to look at your logs of your QA/QCs and things like that. So this is a huge science in itself. And in fact, we have having this degree of anything in biostatistics or masters of public health, and I think Dr. Mirza being with the School of Public Health can also probably talk a little bit more on how these interprofessional relationships between different communities or different practicing disciplines are so important for practicing medicine these days. It's no longer, you cannot be in your silos doing just what you're doing. You got to reach out, you have to interact, be it everywhere. You have to be, as a pathologist, you have to be able to interact with your MLS students, you have to be able to interact with your surgeons, you have to be able to interact with your researchers, epidemiologists, so on and so forth. That's global medicine. That is, you have to treat the patient as a whole.
And also, right now I'm doing a QA/QI project. So that's my month right now with lab directorship. I'm working on a QA/QI project. And I think the most important thing for me is, like, when you get the opportunity to actually work on one of these, you start noticing the importance of, of them and the impact they have for the pathologist, for the hospital, and for the patient. And you're like, wow, we haven't even thought of this, or like, we need to change this. And I like, right now I'm having looking at my data and looking at my things, I'm like, I really want to publish this. And it's an interesting question for you to ask, because I'm pretty sure a lot of people don't even know, right? Once you get into it, once you start doing one, you understand the full concept of, the importance of a QA/QI project.
I think that, the Dr. Viju's point of like the interprofessionalism now, I mean, there's no path forward without that interprofessionalism, right? And so teams are becoming smaller, teams are becoming, more diverse with like different, like, people are, even if you look at on the clinical medicine side, like in the wards, like you'll see that on rounds, there'll be the pharmacist, right? And then there'll also be a nurse, and then there'll be, all sorts of healthcare disciplines are now getting together to do better for it. Like, for example, in this discussion itself, we've talked about molecular, we've talked about global health or public health. We've talked about quality. Cullen is doing a master's. I mean, bioethics, right? I mean, bioethics in pathology, that's a completely, Emily, like, you guys can change the face if you end up doing pathology, but the bioethics of path, like, no one has touched it, with like 100-foot pole, but it's there for the taking. And, and ultimately, when you think of career trajectory, right? If we mentor you towards career trajectories, you can become that niche, right? People are always looking for these niches. The fact that, could you be the next pathologist who has a niche in the bioethics of pathology? I think that that's amazing, right? And so I think we have to have these interdisciplinary programs. We have to overlap. And I think that, pathology is really well suited for this, right? Because it's the nidus that connects all of the different things together. There was a student who interviewed with us. I shared with Dr. Viju. There's so many people who give like examples in their personal statements. And one of the examples was, the pathologist is the trunk of a tree, where the basic sciences are the roots and the clinical sciences are the tree branches, right? And so you connect them. And that may or may not be perfectly true, but the point is that it is a linker, right? It links the pathophysiology of something to the clinical symptomatology of something and everything in between. So if you aren't convinced to become a pathologist, you should hopefully be convinced now, right? And so, Cullen, if we have your permission, do you think we should just wrap up now?
That sounds great. Yep. I hope everyone got their questions answered. I know that there were some things that might be lingering in the chat still, but we're going to have another couple of these events throughout the year, so we always welcome you all to come back. Thank you so much for everything. Thank you for our presenters one more time. And thank you for everyone that came, because this was originally just going to be something that the Loyola community held, and I'm really happy that this was able to be open to the public, and it was something that ended up becoming a really big success. So thank you so much to everyone, and thank you. And with that, we will end it there. Thank you so much.
Thank
Have
you.
a good night.
Good
Happy
night.
weekend.